thoracic setups. Remember, prone thoracic, headpiece is down, foot piece will be out underneath the ankles if you're using the tables over there. Here, we just have to find a table that fits as best it possibly can. Okay? Now, y'all correct me if I'm skipping over anything, okay? So we started with a unilateral contact, right? So we're at T6, tissue pull, P to A, I to S, medial to lateral. Take out additional tissue slack. My contact hand is oriented with my MCPs at about the back of the occiput, okay? Right in the middle. I'm going to stabilize with my piezoform, my stabilizing hand, and the anatomical snuff box of my contact hand. I'm going to wrap the wrist. My episteral notch is slightly below my contact because I'm going to rock forward, transferring body weight onto the patient, and then thrust after having given breathing instructions. Okay? That's a unilateral contact. What's my line of correction? P to A, I to S, along the facet angle. Okay? You're getting ahead of yourself. All right, we have a couple of crossed bilateral contacts. Now for these, rather than being in a fencer stance, I'm going to be in a modified fencer stance, or more preferably a square stance. Okay? For a rotational restriction, in this instance it'd be a right rotation restriction. Inferior hand's my contact hand. Again, I take a tissue pull, P to A, I to S, medial to lateral. Follow that up with my contact hand. I am going to slide my stabilizing hand across the top of my contact hand and down one segment. Line of correction, still P to A, I to S along the facet angle. Okay? And again, breathing instructions would be appropriate here. Okay? So that's our cross bilateral for a rotational restriction. Now I have a cross bilateral contact for a lateral flexion restriction. From where I'm standing, it'll be a right lateral flexion restriction. Okay? So contact hand looks pretty much the same as it did before after that tissue pull. My stabilizing hand actually isn't a stabilizing hand anymore. It's going to be active as far as this thrust. My finger's going to be pointing down toward the opposite hip. Now, I'm contacting the same segment level opposite TVPs. I have two thrusts happening at the same time. With my contact hand or my inferior hand, it's going to be going P to A, I to S along that facet angle. With my stabilizing hand or superior hand, it's going to be P to A, S to I. Okay, you got to tell me both for line of correction on this one. All right? So those are our crossed bilateral contacts. Now we get into another cross bilateral contact, but we call it a rotary setup. Okay, this is where your hand positions make a lot of difference as to what we're doing. So, in this instance, I would be adjusting for a right rotation restriction, and what I've been doing is pairing that with a lateral flexion restriction. What would my lateral flexion restriction do? Right lateral flexion restriction. Tissue pull, P to A, I to S, medial to lateral. Take out additional tissue slack with my contact hand, that's my inferior hand. Then I'm going to slide across the top to the opposite TVP, same segment level. Now my hands here should be at 11 and about 2. Now I'm in a fencer stance to begin with. I am going to step and pivot to a square stance. This is my midpoint. My hands are at 12 and 3. And then if I were to finish the actual thrust, my hands would continue that pivot or follow through to 1 and 4. Now, my line of correction on this one would be P to A, I to S along that facet angle with what? Clockwise toward. If I'm standing on the right-hand side of the patient with this adjustment, my hand positions will start at 1 and 10. It will move to a 12 and 9 position and finish at 11 and 8. Okay? The only difference for line of correction would be that it would be counterclockwise. Okay? All right, that's our rotary setup. Now we have a double thenar setup. Posterior listing, let's say at T10 for this one. contact here, same segment, opposite TVPs. It's a bilateral contact, which means I'm thrusting equally through both hands. It's a posterior listing. Line of correction, P to A, I to S along that facet angle. Now, notice I am inferior to my contact because I'm in the lower thoracics. If I'm in the mid-thoracics, I'd be up over my contact, okay? So that's double thenar for a posterior listing. Now I can do this for a rotational restriction as well. Let's say I use the same setup. It looks the same, but I'm adjusting for a left rotation restriction this time. I'm going to thrust through my opposite or contralateral contact, stabilize with the same side contact. Okay? If I wanted to do a right rotation, what did I say? This is a left rotation restriction that I just set up for. If I wanted to do a right rotation restriction, I'd be standing on the right-hand side of the patient, thrusting through my left-hand contact. Okay? Now, we also have a double knife edge contact. Everybody remembers? Looks like this. Here, here. Now, I can have a body drop. I stay in the position that I'm in here. That would be one thrust, or I can have a hammer chisel, where I'll come down and drop. Okay? Again, P to A, I to S along the facet angle. Now that setup is strictly for a posterior listing. Okay? Nothing else will be asked of you for a double knife edge. Okay? All right. Where are we? Side of table. Now we're going to move up to the upper thoracic region, T1 to T3. I have a side of table, thumb spinous push. I'm standing on his left, so the spinous has deviated to the left side. So I'm going to take tissue pull. I'm going to place the palm of my hand on his trap. I'm going to pull it up and back, and then I'm going to slide my thumb from lateral to medial up next to the spinous process that I need. I'm going to have the patient turn their head away from my contact, this side. Just like that. I'm going to stabilize thenar on the mastoid, a little bit of I to S traction here. My forearm of my contact hand is going to be parallel to the floor and perpendicular to the segmental contact. My line of correction is lateral to medial, in this instance left to right. Okay? I also have, now this one you might need to move to see what's going on. I also have a head of table thumb spinous push. Looks pretty similar, but obviously I've changed my orientation to the patient, so be careful. This one got a bunch of people on midterm, so watch what you're doing. All right, so if I'm using, I'm gonna stick with my left hand. Back of my hand against the trap, A to P tissue pull, lateral medial tissue pull with my thumb up next to the spinous. My forearm of my contact hand is parallel and perpendicular to the segmental contact. This time I can stabilize one of two ways. I can have a bilateral contact with my chiropractic index finger and my thumb, palm of my hand around the back of the occiput. I'm contacting both mastoids bilaterally, and I'm tractioning a little bit of I to S, so I'm here. Or I can have the patient turn their head away from my contact, and I can slide up with my hypothenar eminence on that mastoid, coming up just a bit higher, and get into position yet again. Forearm parallel to the floor, perpendicular segmental contact. Line of correction is lateral to medial, and for this one it'd be right to left. Good? All right. We have a side of table pisiform TVP push. Again, fencer stance, favoring the head of the table. I'm going to take a tissue pull, P to A, I to S, medial to lateral, out onto the TVP, and we'll follow it up with additional tissue slack that I've taken out with my contact hand. That is my inferior hand. Now I'm going to have the patient turn their head toward me for this one. Okay? I'm going to stabilize again with my thenar on the mastoid, cupping the ear, a little bit of I to S traction, and with my contact, I want to lean just a little bit forward of my contact hand, because I'm accommodating for the kyphosis. Line of corrections, P to A, I to S along the facet angle, accommodating for the kyphosis. Okay? It's the side of table pisiform TVP push. So what have we not done? Supine adjusting. And hang turn. Anytime we put the patient in the supine position, I want to raise the headpiece a little bit. And this one doesn't raise up quite as easily as the ones on the other room. Okay, so very generally put, I can adjust any listing that I adjust in the prone position in the supine position. Okay? I can do it by making my contact from the same side, which would be an ipsilateral contact, or I can do it by reaching around the patient, and that would be a contralateral contact. Okay? Now, I can set the patient up in one of two ways. I can have crossed arm contact. See, I'm going to do ipsilateral this time. Crossed arm, elbows approximated as best you can. You're going to contact the inferior elbow at the very least. If your hand is big enough to span both elbows, great. Okay? Be sure to remember that when you get over the patient, turn your head, position your body such that elbows are right in the middle of your chest, mid-pec, or even mid-sternum if you can get there. Okay? I don't want to be out here. Okay? So roll away from me just a little bit. Find my contact, and for a rotational restriction, okay? So if I'm contacting his right side, what am I adjusting for? Left rotation restriction, right? Thenar on that TVP, open hand contact behind. Okay, I know you can't see that, but that's what it is. Got my stabilizing hand. I'm over the patient, turning my head. I'm going to have the patient take a deep breath, blow it out, and then I'm going to thrust A to P, I to S. Okay, with body drop. As for rotational restriction, if I had a lateral flexion restriction, it would be that very same setup for an ipsilateral contact. Now, I could adjust for a left lateral flexion restriction. All I'd actually do is I'd bring the patient over just a little bit into lateral flexion and adjust. Okay? That's the only change that I would make for that ipsilateral contact. If I have a posterior listing, now this becomes a bilateral contact, and you're going to use your hand in this position, contact over your DIPs and the heel of your hand here, opposite sides, okay? And I'm going to be on the segment that is posterior. So if it's T6 posterior, I'm setting up on T6 bilaterally, okay? If I have an anterior listing, now I'm doing the same type of setup, only I'm setting up on the segment below. Okay? Everybody got that? If it's posterior, same segment. If it's anterior, segment below. Okay? Now, contralateral just means I'm reaching around the patient. Okay? So I can do all of the things that I just described to you by reaching around that patient, placing my contact, and getting into position. Okay? Line of correction's the same, A to P, I to S. You do not need to tell me along the facet angle. Just tell me A to P, I to S. You got that? You're doing good. Okay? Now the other way that this can be done is to change the patient's position and have them in a pump handle position, which basically I just want to put his hands on top of his shoulders, just like that, and we'll relax. It's just a different position for the patient's arm. That's all it is. The contacts, everything else is just about the same. About the only thing that isn't is the stabilizing contact, where I'm using my forearm across theirs. Their elbows are in my chest. Okay? Now that's about as abbreviated a supine discussion as I can possibly have. Any questions? No? Okay. I can use, you can relax. I can use that open hand contact to adjust ribs as well, mid to upper thoracics. All I'm going to do is change my segmental contact point from the TVP out onto the rib, the angle of the rib, okay, lateral. That's the only thing that really changes. Okay? All right. I think that's all the thoracics. Have I missed anything?
No.
That's all of them. All right. Since I have my patient in supine position, we're going to start on the cervicals from the supine position. And what I've got here is a supine index TVP or pillar push. Just depends on what segment I'm contacting. If it's a TVP push, I'm on C1. If it's pillar push, I could be anywhere from C2 to C7. Do not forget, the best way to remember this is the angle of the disc is going to kind of rule the day here. If I'm in the upper cervicals, that means C3, C2, and C1. My line of correction is P to A, I to S. If I'm at C4, that's kind of my break point. I'm just saying P to A. If I'm in the lower cervicals, C5 to C7, it's P to A, S to I. And that angulation is a slight bit of angulation. It's not extremes, okay? All right, so supine index TVP push. Stabilize, cupping the ear, fingers running around the back of the occiput. I'm going to take a tissue pull with my lateral index onto the TVP. Come back to neutral. I'm going to laterally flex, but when I do, that's just at the occiput, or occiput C1, okay? And then I'm going to step around the patient just a little bit so that I can get, and we got some movement. So, I'm coming here, I'm getting behind my contact, my elbow is low enough to be posterior to my contact so that I can thrust through that joint in the appropriate fashion, P to A, I to S, okay? Now that is a supine index pillar, TVP push. Pillar just means I'm contacting the articular pillars, not the TVP, okay? Now that's for cervicals. What I skipped over was the occiput, so we have a couple of them in the supine position for the occiput. I'm standing at the side of the table, so I might as well do a supine occiput lift, okay? Now, guys, you don't start from the head of the table and then move to the side of the table. Just start here when you set up for this. I will be adjusting for a right lateral flexion restriction. I'm going to have him turn his head away from me. I'm going to slide my hand underneath his head, cupping the ear, heel of my hands just above his ear, fingers running down cervical spine. I'm going to take my thenar, I'm going to contact the inferior mastoid, cup that ear, and then my arms are akimbo. I'm going to laterally flex at the occiput C1. My line of correction is lateral to medial, I to S. Got a 45-degree angle toward the floor, okay? That's my supine occiput lift. I have a supine occiput push move. Now I'm going to do a left posterior superior occiput, okay? Again, I'm going to cup the ear that I'm stabilizing, which will be the right side. Fingers running around the back of the occiput. I'm going to turn his head and find my spot where I want to contact. Hypothenar contact. Slide up with your tissue pull above that supramastoid groove and drop right back down on it. And I'm going to come back to neutral, dropping my elbow. I'm going to laterally flex. Now I need to probably step toward that side of the table just a little bit. Laterally flex, rotate. My forearm, my fingers are all in line pointing toward the opposite shoulder. That is the direction I want to go. My line of correction is P to A, S to I, lateral to medial. Okay? That's my supine occiput push move. I think I've touched on all of my supine cervicals and upper contacts. Now, I want you to turn over for me. Again, we're going back to prone adjusting, so I'm going to lower this headpiece a bit. Now this time, I need to be sure that the patient is going to be in a prone position with the tops of their shoulders to the top of the thoracic piece. I want to have this space between the headpiece and thoracic piece open so my hand will fit in there where I'm making my contact so I can actually thrust appropriately. Okay? Now, we have 3 contacts in the prone position that we can have. We can have a prone index pillar push ipsilateral. That's going to be a superior hand contact. I'm going to take, and it's a lateral index contact, I'm going to take a P to A medial to lateral tissue pull onto the articular pillar. I'm going to have the patient turn away from my contact, following through with them. I'm going to cup their ear, thenar on the mastoid, I to S traction. My forearm is parallel to the floor, and if I'm at C4 where I am, my line of correction is P to A straight through. Okay? If I'm in the upper cervicals, I'd have a slight bit of I to S. If I'm in the lower cervicals, a slight bit of S to I. Okay? Now that's the ipsilateral contact. What was my line of correction again? At C4, it's just P to A. Okay? All right. Now we've got a contralateral contact. This time, I'm going to be adjusting for what kind of a restriction?
Left.
Okay, which direction?
Left rotation.
Left rotation restriction because I'm contacting his right side. My inferior hand becomes my contact hand. Again, I'm going to take a tissue pull P to A medial to lateral, sliding out onto that articular pillar. I'm going to have him turn away from my contact, which is toward me this time. This is a little bit more awkward, so come over the patient. Again, thenar on the mastoid, cupping the ear, I to S traction. And again, if I'm at C4, I'm going straight through. And I do the best I can to get over the patient and get into the best position. Okay? Line of corrections did not change for that. All right? Last but not least, in the prone position, excuse me, is a bilateral contact. Now, my contact is my hands are going to be together in this fashion, pointing down. Okay? And it is bilateral, double index, lateral index contact. Okay? So if I have a posterior listing, tissue pull, and I would be thrusting at C4 again straight through. Now my suggestion is that you keep your elbows bent slightly, square your shoulders to the head of the table as best you can. Okay? If I'm in the upper cervicals, I'm going to have a slight bit of I to S thrust to it. Lower cervicals, S to I. Now if I have a rotational listing that I am trying to adjust in this position, okay, neutral position, again, it's a bilateral contact, but this time, like with my double thenar, I'm thrusting through one hand more than the other. So, since I'm standing on the left-hand side, I'd be adjusting for a left rotation restriction. The setup looks the same, except for my, what I'll call my contact hand, which is my contralateral hand, is going to be the one on top. And I'm going to thrust mostly through that hand here. Okay? Now, don't slide your hands down so far that the web of your hands touch the back of the head, or back of the neck, head. Everybody remembers all that? Mm-hmm. Good? All right, those are our prone setups. All we've got left are the seated setups.
Yeah, the occipits.
Oh, thank you very much. Of course, these should be our two easy ones.
Mm-hmm.
Okay, bilateral contact. If I am standing inferior to my contact, what am I adjusting for? What is it?
AS occiput.
Okay, flexion restriction.
Yeah.
Is how it'll be given to you. So I'm here, and I'll be thrusting P to A, what? I to S. Okay? Now, if I want to adjust for an extension restriction, I'm going to have the patient bring their head up just a little bit, right there. I'll make that very same contact on the base of the occiput. I'm going to come over my contact, and I'm thrusting P to A. Okay? That's for an extension restriction. Okay. I think I got all of my prone stuff now, right? Let me have you sit down. All right. Seated occiput. I'm going to have, and I'll better do it this side. Okay, I have a left lateral flexion restriction. I'm going to bring my, what am I doing? I'm getting it backwards. See, this is what happens when you try to go this fast. All right, so I have a left lateral flexion restriction. I need the patient, I'm gonna come forward with my left leg. I'm gonna have the patient lean back against me. Head relaxed, there we go. I want you to turn to the right side for me. There we go. I'm gonna use my left hand to make a contact. I'm gonna take a P to A, I to S tissue pull. I'm just sliding up onto that mastoid. I'm gonna cup the ear. Make sure I've got the patient neutral position. I'm gonna reach around with my other hand. I'm gonna back up my contact. Don't put a lot of pressure on the jawline, but if you happen to be touching their jaw, that's okay. Now from here, we wanna bring them into pre-tension, which means I'm gonna bring my chest out, shoulders back. Shoulders will come up a little bit in the process. And I'm gonna have a scooping motion this direction. Just like that. Now that's pre-tension. My line of correction is lateral to medial, okay? I to S because it's a lift with a scooping motion. That's what I want you to tell me, okay? That's for our seated occiput lift. Now we have a seated index TVP or pillar push. Depends on what segment I'm contacting. So this is cervicals. I'm just going to stabilize for a second so I can take my tissue pull. Palm up. Slide up onto that posterior TVP. If I'm at C1, I'm going to let my hand slide down. To cup the ear and stabilize, I'm going to laterally flex and then rotate. I'm letting my shoulder relax, my elbow down so that I can thrust through that opposite eye. P to A, I to S. Okay? If I'm in the lower cervicals, P to A, S to I. Now with him, I would have to either find a lower table or find something to step up on to be able to do my lower cervicals because I can't quite get there like I need to. Okay? So that's the cervical push move in the seated position. We have a seated pull move. What's my cardinal rule here?
Don't stand between the patient's legs.
Don't stand between the patient's legs. All right. That's okay to stand out in front, just not in between. Okay? But we are going to be at an angle to the patient, and I'm going to adjust for a right rotation restriction. So I'm standing on the patient's right side. I'm going to reach across the patient with my right hand using my chiropractic index finger. I'm going to take a tissue pull, P to A, medial to lateral, just sliding, in this instance, to that TVP of C1. I'm then going to let my hand slide down, cupping the ear, fingers running straight up or toward the back of the occiput. I'm going to laterally flex at my signal contact, and I'm going to rotate. Patient probably is looking up at me about now. I've got him to tension. If I start to see that shoulder rotate around, that's as far as I need to go. My thrust is going to be straight back and up toward me for the upper cervicals. Again, P to A, I to S. If I'm in the lower cervicals, I'm dropping my elbow just a little bit, P to A, S to I. Okay? Now, I think that's everything. The AS occiput. That's why I'm glad I got you guys here to keep an eye on it. The AS occiput, I'm just standing behind the patient. I'm going to make a bilateral contact. Hypothenars, just over the supraorbital ridges, and my thrust is a scooping motion, which basically means I'm going A to P, S to I, this direction. Okay?